one or two people who are looking at trying to log in, including the vice chair for the committee, and the chair was not going to be able to make it today due to a conflict. But there is a quorum present. Unless there's an objection, what we can go ahead and do is we could start with, rather than doing the introductions, we'll wait for the vice chair to join on in. We could start with the program update. We are recording this, and of course the updates would be available. But is there any objection to doing that, just so that we're actually cognizant of and respectful of people's time? Is that okay with the members of the committee?
I have no objections.
It's great, Dominic. Thank you.
I agree.
Okay, so I'll go ahead and get started with that aspect. Let me just, and good morning, everybody. Welcome, everyone. Again, we'll do the introductions once we have some of the other folks that are on, that are trying to get online. Let me go ahead and share. Oh, actually, Libby, it's just letting me share files and content, or I mean, and whiteboard. Let me see. Well, sorry, everybody. I thought here I was ready to start up with all of this. There we go. Thank you, Libby. Perfect. Okay, so everybody should be able to now see the presentation from the Medical Cannabis Program Division. And again, this is an update on some of the items and where the enrollment in the program is with regard to patients. And so we'll go through that and some materials, as well as some questions that have come up with different individuals, or that different individuals have asked with regard to medical cannabis versus recreation cannabis, and what really some of the similarities and some of the difference are as far as how they operate. And so I'll go on through these now. Before I get started on that, as always, we want to recognize the ancestral lands of the peoples of the Apache, Navajo, and Pueblo, both past and present. And with gratitude, we pay our respects to the land, the people, and those communities that have contributed and continue to contribute to what we now know as the state of New Mexico. And some of the goals and missions of the Department of Health, and especially with regard to the medical cannabis program, is to expand equitable access, ensure safety in healthcare environments, help improve health status for all New Mexicans, and support each other by promoting an environment of mutual respect, trust, and open communication, including the needed resources for staff to be able to serve New Mexicans and to grow and reach their goals. And the Linen and Compassionate Use Act, of course, the purpose of this is to allow the beneficial use of cannabis in a regulated system to help alleviate symptoms caused by the debilitating medical conditions and their medical treatments. So we do have New Mexico, the medical cannabis program has continued with increased enrollment. We do know that quite a few people had thought that we might see a drop in enrollment. And while we have seen some dip in new enrollment numbers, the program continues to increase. You may recall last month we had 131, or I'm sorry, 2 months ago, we had 131,000 patients enrolled. We are now at 133,000 patients, and that's as of the end of March of this year, so March 31st. The 3 counties with the highest enrolled number of patients remain the same, with Bernalillo, Santa Fe, and Doña Ana counties. And there are still the 669 out-of-state enrollments. And those are the individuals who enrolled during the brief period where it was legal for out-of-state individuals to enroll in the program. And that was back in 2019. So you can see here how patient enrollment has increased over the past 5 years, and it has been very steady during this time. We do anticipate that it will actually begin. We had a little bit of a a fewer number of applications this past month and a half to 2 months, but we are already seeing that begin to tick up. And part of that was what we knew would occur and what we projected would occur would once recreational and adult use was actually being started, that individuals would turn around and say, oh, I don't need to enroll in the medical program. But as they're going to the dispensaries and making their purchases, what they're realizing is that being able to be enrolled in the medical program means they can purchase their cannabis up to their adequate supply without tax. And so we're already starting to get inquiries on people wanting to enroll, or people who had let their enrollment lapse with adult use coming on board and who are now saying, I need to re-enroll again. How do I do that? And so we'll continue to see that increase over the next several months, we think. And the most commonly enrolled qualifying conditions remain the same as from our last meeting. There are 28 qualifying conditions, but the three most often conditions that are utilized for enrollment are post-traumatic stress disorder, severe chronic pain, and cancer. And so you can see these are the actual numbers for it, and it's just under 73,000 individuals for PTSD, 40,000 for severe chronic pain, and 6,660 for cancer. And the percentages of these remains very stable based on the number of individuals that are still enrolled in the program. The percentages remain there. Last month, or 2 weeks ago, 2 months ago rather, it was again at 89% of all the active enrollments fell within these three categories, and that is still the case 2 months later. We have been working as far as cleaning up and gathering information on ethnicity and race. Now, one of the things you'll notice is over the years, how this was gathered has changed at different points in time. And so these are the current categories that are utilized. And these are optional questions. So the ethnicity race is optional. So not everybody answers it. But out of those who have answered it, we do again see it does reflect fairly well with the population in the state, although it is primarily among individuals who identify as Caucasian or Hispanic and Latino. And then gender is almost even as far as the binary male and female. One of the things that, and we're working on this as we move forward, is that for individuals who identify as non-binary or outside of the binary male and female, we are starting to get better responses on that, especially as we have included that. And we find that, that's very important for us to be able to reach and ensure that we're reaching people who need to be enrolled in the program and who have a desire to be enrolled in the program. And so it's been very good to see that those numbers are actually increasing, but it's not been a lot yet. And one of the things we plan on doing is in the next year or two, as we do gather better data with regard to that, being able to show a difference of when this information first was being gathered to where it is at that point in time, so that you can see how the program has improved with gathering the demographics. And then the age ranges. And as you can see, our age ranges of patients really is fairly consistent through most age ranges, with the exception of 0 to 20. With really the biggest variation is over 71 is at 16, just under 17,000, and the largest age group being 31 to 40 at 26,000. And so that's a very interesting thing to see, because for many years we did have a lot of people say that most of the people enrolling in the medical program were people who were younger, and they were just doing it as a way to access cannabis without having adult use sales being available. But what we really do see with this is it really is across all age groups, and that people really are enrolling in the program for their medical needs. So I'm going to actually turn this over to Andrea Sundberg. Andrea, I'll control the slides for you. Just tell me when you want me to switch them. Andrea
Okay.
is our health program manager for the program.
Good morning, committee members. Thank you for being part of this exciting industry. I've been with the program 10 years, so I've seen a lot of changes, and it never ceases to amaze me when the changes come about. So I'm going to kind of talk about the difference between the medical and adult use systems that we have, and why people continue to enroll, and how we're working with the Cannabis Control Division that oversees all the licensees. So one of the big differences is between medical and adult use is how much product you can actually have on you outside the home. So medical patients can purchase 425 units, which is approximately 15 ounces of product over the course of 90 days. This would be equivalent to somebody smoking about between 4 and 7 cannabis cigarettes a day. And that's if you're rolling some real good fatties, but it's because the typical marijuana cigarette contains about 0.3 grams, and our producers typically sell them between 0.75 and 1 full gram of product. An adult use can purchase up to 2 ounces of flower, 16 grams of concentrate when they walk in, and that is how much they can carry with them outside the home. So an adult use person can go in and purchase 2 ounces. They then have to take that home and cannot be in possession of more than that outside of their home. Another big difference is the age range. So for adult recreational use, you do have to be 21 or older and be able to present ID showing that you are 21 or older. And anybody, any age can enroll in the medical program. If you are over the age of 18 or older, you can enroll without any kind of permission. And if you are under the age of 18, so 17 and younger, they do have to have a parent or guardian that is actually responsible for purchasing the product and controlling access to that product. I think right now our youngest enrollee is approximately 9 months old. And I think our eldest one is 103. So we have quite an age range. Another big advantage of being in the medical program is the sales tax. The legislature did recognize this for medical purposes. So patients enrolled in the program do not have to pay the sales tax, which can be up to 20%. So that has been a real big benefit for those patients that are enrolled in the program. Next slide. For medical patients, they also have additional legal protections when it comes to probation. And obviously that possession issue. So somebody that's on any kind of community sanctions, probation, parole, home monitoring can be enrolled in the medical program, whereas adult use they can say for adult use of somebody on probation, parole, that they can't have cannabis in their system. However, they're using it medically, they are allowed to use that medically. And again, that possession issue is another big issue. Patients must submit an annual certification. So the cards are valid for 3 years. However, patients still have to submit an application every year to confirm that they are still eligible for the program. And it's also a way to ensure that these patients are at least seeing a medical provider once a year. One thing we do know with cannabis is it is excellent at controlling for pain. And sometimes your body has pain because it's trying to let you know something's going on. So we do think it's important for people to see their medical providers at least once a year to make sure everything is okay. So that's why we do currently require that certification to be submitted every year. Obviously, the Department of Health oversees the medical cannabis program and the medical cannabis registry, and the Cannabis Control Division in the Regulation and Licensing Department oversees all licensing. So they license the dispensaries, manufacturers, the people that grow, the labs, the couriers that transport. They're responsible for licensing and ensuring compliance for all of those agencies. Next slide. One things the adult use and medical do have in common is there's no public use. So you cannot be driving down the street, sitting in parking lots in your car, using it in any public areas. People can gift product to another person, but they cannot sell it. There can be no financial consideration, so there cannot be any exchange of money, goods, or services for the product. So people can, anybody 20 or older can grow their own plants, up to 6 mature and 6 seedlings with a maximum of 12 mature per household, but they cannot sell that product to anybody. They can give it to them, but they can't sell it. And they can't do things like, well, here, if you buy this t-shirt or this piece of art from me, I'm going to, give you this gift of some product. which some agencies tried to do. They cannot do that either because that is considered financial consideration. All product must be stored and kept secure. Recently, our lovely health educator, Ms. Bissio, did create some guidelines that are available on our website for how to properly store product and keep it safe and away from children and pets. And you cannot transport product across state lines. It has to be purchased from an intrastate source. So people coming in from Colorado, Arizona, Texas, if they come in and purchase here, they have to use the product here. They cannot take it back to their home state and vice versa. They cannot bring a product from those other states. They do not have legal protection for that product. We always like to say, buy local, buy New Mexican. So it goes for this product as well. And I think that's all I have to cover on that. Do we want to take questions now or at the end, Dominic? Oh, oh, oh.
Sorry about that,
Yeah.
everybody. As I tried to unmute, the slideshow decided to go everywhere. Now, I think if people do have questions at this point, it would be great to go ahead and answer them.
I would,
Is there anybody who has any questions so far?
I think Ryan had one.
yeah, Dominic, do you know, so I think you had mentioned that most providers or places have a provider who will see individuals and they charge a fee. Have you guys seen those fees or go down at all with the adult use, recreational use being allowed?
We don't actually, we don't monitor it specifically as to what the fees are. However, from what we've heard from patients on the phone, Gary might actually be able to answer that a little bit because he's spoken with some of the providers and with them also. Has there been much change in that, Gary?
No, pretty much the providers are charging the same fees that they were previously. Now, mind you, there are fewer providers. Some have dropped out because they felt that the recreational would reduce the number of applicants, where it's actually increased them. There have been other providers that are actually not charging a fee at all, and they are sometimes doing it pro bono and sometimes charging an insurer, but that's more for a psychiatric evaluation. So if you had to ask me, all in all, I do think that it's probably somewhat reduced. Those providers that had lower fees are seeing more traffic than those that had extremely high fees.
I was just wondering at what point does the tax rate offset the paying the fee for the provider to certify you? So where I was trying to figure out if that.
Yeah, given the feedback, I think that the tax incentive is definitely a large one, and it is well worth the patient's interest to go ahead and see the provider. I would say a typical fee is probably $40 to $65, and that's going to offset the tax after one or two visits, most likely, or a couple visits per se.
I have a quick question. Sorry, I just figured out how to unmute. I'm on an iPad. So with the different formats. So RLD now regulates all providers, medical and recreational, is that correct?
Yes, that's correct. All the licensees are regulated by RLD.
And so are the quality standards the same then? There was some discussion of quality in the last couple of meetings, and I wasn't sure if therefore they're requiring the same thing of both medical and recreational distribution.
Actually, that would be a great question for one of our other guests who we'll introduce in a little bit. Emily Kaltenbach, who is the chair for the Cannabis Regulatory Advisory Committee. Or Emily, would you like to answer that or talk about that a little bit now? I know I'm putting you on the spot there a little quicker than your presentation scheduled or your discussion.
I heard my name and I tried to
Oh.
get off video. So will you repeat it? I'm happy to address about the quality issues, but I want to know specifically.
Well, just
So
if, oh, go ahead, Haley.
well, the question is, are the quality requirements for medical and recreational the same through RLD? Because in the past, it wasn't quite clear what the medical versus recreational might be or how they might differ.
Yeah, that's a really important question, something we dealt with for many years that kept coming up. Yeah, the quality have to, as Andrea actually mentioned in the chat, adhere to the same testing standards. I think where it gets more difficult is around the types of products that might be stocked in a given retail location. So whereas patients may require or need certain types of medication that may not be as popular in a recreational or an adult use market, I see that as more of an issue than the quality standards, or may want, higher THC. So there have been some discussions around that, and I'm happy to get into a little bit of that in my presentation and around the regulatory advisory board. But quality regulations are the same.
Okay, thank you.
Yeah, and I do want to say, with the Cannabis Control Division, we're continually working with them, and they really care about the quality of the product going, especially to patients. They do monitor every day what products are in stock, and when we get a complaint from a patient, we send it to them, and they do look into it. So they've been excellent to work with, and I've really enjoyed my time working with them, and they really do care about making sure that people are getting good quality product, and that they're trying to look at how they control for making sure that some products aren't held back for only recreational use. So they do look at that on a regular basis, and when we get those complaints, we send them over, and they send people out to talk to those dispensaries to find out why they're doing that. So just a little shout out to them that they've been actually really great to work with, and we both have learned a lot from each other, so it's been wonderful.
Okay, are there any other questions right now? So I did want to bring up one clarifying point, and thank you to Emily on this, and that is that the only time for probation or parole that somebody on adult use may have restrictions with regard to purchasing or possessing cannabis is if it is specifically a portion of their conditions for probation or parole. So when we say that they may actually restrict it, we don't mean that it's an automatic item. It is something that has to be listed as one of the conditions of their probation or parole. So just wanted to make sure to clarify that. Okay. Oh, Ryan?
Sorry, I did one other question. I know I brought this up in another meeting, especially about Roswell and the council there, and talking about some of those issues putting forward for people to get licensed. I saw on KRQE News the other day the article about people being left out of the cannabis industry, and I didn't know, like, are you guys seeing issues with people getting licensed? Is that like a similar to issue of what is happening down in the southern part of the state, or?
Well, what I can say on that is there are issues for medical cannabis in that county, but what has happened is Roswell itself, and Emily, please correct me if I'm wrong on this, but that their city council has actually passed a resolution at this time that actually restricts the recreational at this point, and that is where those issues are coming in. And so that's a local issue and restriction, not a statewide. I don't really know of too many other communities that have done that at this point. I know there have been some considerations in some other city councils and county commissions, but nothing that's really been to that extent. Emily, are there any other additions on that, or or did I?
No, yeah, I think that was great, Dominic, to mention that, a lot of the restrictions are really at a local level. I do want to flag that in the statute, local jurisdictions are not allowed to ban adult use sales or manufacturing or production. The only type of license that they can ban are the consumption spaces. And so if we see, and I've heard that local jurisdictions are just saying, we don't care about state law, we're going to ban it. It actually is illegal to do that. I mean, there can be lawsuits that are brought up. So I just do want to flag that piece. Thanks.
Thank you, Emily. And so I think, Ryan, really that's something that over the next several months, there'll be some more movement with regard to it. But as adult use sales just started April 1st, it's still very new, and a lot of that still has to be worked through. I think that's fair to say, Emily, don't you?
Yes.
Okay. Well, let's go ahead in the interest of time, because I know we actually have several folks who have joined in and moving forward. I'll turn it over to Libby Bicio, who is our health educator for the medical cannabis program. And Libby, I will move to your first slide.
Awesome. Thank you. Hello, everybody. It's great to see you all here. I just wanted to give you a little bit of a brief overview of what we've been doing in our education and outreach. Thankfully, during the pandemic, although we have been at home, Gary, Dr. French and I have been able to still do a great amount of education and outreach within our community. Some of those populations include treatment courts and therapy teams, judges, law enforcement, medical providers, and of course, our patients. Excuse me. So that's been really great. Ooh. So we're thankful for our online platforms to allow us to do that. We've also have updated our educational resources that we pass out to our patients and what's available online. For example, this is our patient guide that we send out to all of our patients when they receive a card. It gives them information about possession, any sort of safety reminders, differences between medical and adult use markets, and a little tracking sheet where we always recommend our patients to kind of monitor what they're consuming and if a particular product works for them. So this is super helpful. And of course, wanted to give a lot of credit to our comms teams because they've been really great at helping us kind of revamp the look of things and keep that consistent. Next slide. And so even before the adult use market came into play, safely storing cannabis was an important issue, but now as it's a little bit more readily available and maybe more present in homes and around children or pets, we felt it was important to make sure that we had enough resources out there to advise any consumer on safely storing cannabis. Of course, we have some other resources on our web pages as well. Those are still coming through from our comms team, but this one, of course, is very relevant right now. Just making sure that everyone is safe and safely consuming. So it has been great to get those new resources on the website. And if you want to take a peek at those, the web link is there. We have also been privileged to partner with a few other agencies. This one I created with CYFD, specifically Susan Merrill and Dr. Tristan Maroney. And so this is a resource we created for the CARA program, which is the Comprehensive Addiction and Recovery Act, which is a national legislation that promotes programs and strategies to address the impact of substance use and abuse disorders in communities and on families and individuals. Specifically in New Mexico, the CARE program focuses on supportive care for pregnant people who have been affected by substance use, and with the coordination of any services that these individuals and their families may need. And this is a resource that they will pass out or send out, or if they're working with a specific person or a list of providers, they send this out. So just another great opportunity that we had, and an opportunity to get more information out into the community. That's it for me.
And yeah, and just to let everybody know, we are constantly working on other educational materials. There are other items that are available on the website. This was just an example of some of them. There'll be others that are coming out soon, and that we're just waiting on our graphic designers and our comms team to actually make them look a little bit better. We're great on the content. We're not so much the graphic designers to be able to make things, the flyers appealing to individuals to be able to watch. So we do have that. Are there other questions at this time? Okay, well, it does look like at this point, we do have more than a quorum, of course, for individuals, but it looks like our vice chair, who is going to be joining to chair the meeting today, is caught up with a patient. So what I would like to ask is there a committee member who can serve or who would not mind serving as the chair for the official aspects? And I can help to facilitate to move through the agenda in other ways. Because we do need a member to actually call the meeting to order officially.
Dominic, I'd be glad to do that if you need help.
Thank you. Thank you, Ryan. Ryan, would you mind calling the meeting to order?
Yeah, so I'd like to call this meeting on April 26th to order. And I guess we need to review those minutes. Is that?
Yes, the question
Or do
the next
introductions.
item, introductions first.
Okay.
Yes. So, and if you'd like, I can go down the list and ask people to introduce themselves.
Yeah, that would be great, Dominic. If you'd help me out with that, that'd be wonderful.
Sure. So I'll go through the committee members first, and I'm just going to go down the list. Alan, do you mind introducing yourself? Oh, it looks like you may have frozen up, Alan.
I think he was about to start talking to us.
Of course. It's always, well, we do have Alan Plymel, who is one of the members of the committee, and when he comes on back, we'll let him go ahead and introduce himself. And actually, the next person I would like to, oh, and Alan, are you back?
I'm here.
Oh, great. Could you go ahead and just briefly introduce yourself?
Yes, Alan Plymel, resident of Deming. I work a couple of days a week at an internal medicine clinic, and happy to be on this board and see what we can do more moving forward.
Great. Thank you, Alan. And actually, the next person I'd like to introduce, this is Dr. Eleni Bukavalas, who is actually a new member to the committee. And I hope I pronounced your name correctly. Did I do well on that? I realized I haven't actually pronounced your name out loud since we first spoke. Would you mind introducing yourself briefly?
That was perfect. And I know it's a tricky one. Good morning, everyone. I'm Dr. Eleni Bukavalas. Please call me Eleni. I am a practicing emergency physician with Presbyterian Healthcare Services here in Albuquerque. I also have a master's in public health. My current research works specifically with patients with opioid use disorder and treating these patients with buprenorphine. But in conjunction with that, we're currently working on education and advocacy to
Thank you, Eleni. Haley Faust, will you mind introducing yourself?
Yeah, I'm originally a preventive medicine physician. I'm a past president of the American College of Preventive Medicine and have an MPH and a master's in philosophy and bioethicist. I did a fellowship at the University of Toronto in bioethics. And then I spent 30 years as a venture capitalist after running healthcare systems. So I understand how companies form and start. I was involved in about 25 startups during that time. Mostly retired now, but I continue to teach epidemiology part-time and bioethics.
Great, thank you, Haley. And Katie Witkowitz?
Yeah, hi everyone, Katie Witkowitz. I'm a professor at University of New Mexico. I do research on treatments for substance use disorders and harm reduction approaches. And very, very glad to be on the committee, learning a lot. Thanks, everyone.
Thank you, Katie. Matteo Pearson.
Hi, I'm also a researcher at UNM, also work at Center on Alcohol, Substance Use and Addictions. I founded a scientific organization called the Research Society on Marijuana.
Thank you, Matteo. Matt Clark. Oh, Matt, you are muted still.
Okay, we'll try it again.
There we go. Perfect.
Matt Clark, Emergency Services Director, Otero County, Emergency Management and EMT Basic.
Great. Thank you, Matt. And Ryan Nix.
My name is Ryan Nix, Executive Director of Alianza of New Mexico. We have 2 offices in the southern part of the state, Roswell and Las Cruces. We provide service for people living with HIV. I've been in the nonprofit field for, I can't even do the math, a long time now. So mostly doing HIV work and harm reduction services. So it's a little bit about me.
Great.
Then do you want to do staff? Is there anybody, do we miss anybody else?
So we've introduced all of the staff with the exception of Dr. Gary French. Gary, do you want to do a brief introduction?
Hi, I'm Dr. Gary French. I'm the medical director here for the medical cannabis program. I've been here with the program since February of 2020. And again, learning something every day. We have a great team. Glad to be here.
Thank you, Gary. And then we do have a few guests who are doing presentations. You've already met, but if Emily Kaltenbach from the Cannabis Regulatory Advisory Committee. Emily, would you like to introduce yourself any further at this point?
You know, I'll save my introduction. How's that?
Okay, that sounds great.
Thanks.
And then we have Haley Peterson, who is with our Epidemiology and Response Division at DOH. Haley, would you like to say a couple of words before to introduce yourself?
Sure. Yeah, Haley Peterson. I'm with the Substance Use Epidemiology section here at Department of Health.
Thank you, Haley. And then we also have Mike Sophis, who is with CPPC, and I will let him introduce himself as well.
Hi guys, I'm Mike. Yeah, I have a PhD in behavioral psychology. I'm the Director of Research and Innovation at Cannabis Public Policy Consulting. Thanks for having me.
Thank you, Mike. And then we do have a few attendees, all of whom are actually, and I hadn't pulled that up earlier, so my apologies on that, but all 3 of whom are part of our medical cannabis program. It is Brenda Martinez, who is our staff manager for our patient registry system, Kathy O'Gary, who is our project manager with regard to BioTrack and all things IT, and then Selena Montoya, who is our budget analyst and our fiscal staff member. And so those are on our attendee list. So at this point, Ryan, the next step would be the minutes from the previous meeting.
Okay. I'm going back and through my emails. Did everybody have a chance to look at minutes? I know I've got the biographies and the agenda. I'm trying to locate those minutes.
And Brian, what we actually are utilizing mostly for the minutes is the video recording from the previous meetings.
Okay. You know when those were sent out? Are we okay with just approving them based on the video? Because I don't see that.
You can approve them based on the video, which we do also post up to the website.
I'd be open for a motion for someone to accept the minutes as viewed in the video.
So moved.
Second.
Give a second. Okay, thank you very much. And then where are we at with presentations then? I know we kind of got a little out of order in the agenda. Do we have someone that needs to go next?
Yeah, this would be Emily Kaltenbach.
Okay. Emily, we're ready for this introduction and for you to be our next presenter.
Well, thank you. Thanks, Ryan. A pleasure to be here and nice to meet everyone. I'm Emily Kaltenbach. I'm here representing the Cannabis Regulatory Advisory Board, which I think of as a sister board to this board. But I'll do a little introduction to myself and the organization I represent and some of the history, and talk a little bit about potential ways we can work together. But I'd also like to just reserve, I know 10 minutes is not a lot of time, that if folks have questions about that I can try to answer on the regulatory side or about the statute, I'm happy to do that. But I come to this work from the perspective of public health and social justice and equity and racial justice perspective. I work for the Drug Policy Alliance. We're a national advocacy group. We've had an office in New Mexico over, well, gosh, now almost 22 years. I've been with the organization about 11 of those years. Directing our state office. Although we are really small now, we really don't have much of an office. It's me, and most of my time now is working nationally on criminal, legal, and policing reform, but very engaged in drug policy reform here in New Mexico. So our organization was very active in the advocacy for adult use cannabis, but that goes actually, our history with cannabis goes back before my time, in which our organization was an active advocacy group in getting the medical cannabis program online. So we worked both on helping draft and write the law to the regulatory piece. And so our goal with adult use and why we advocated so strongly for it here in New Mexico is really rooted in public health. It's rooted in making sure there are strong consumer protections. It's about reducing the harm of prohibition and the public health harms that prohibition has caused to many individuals and families across New Mexico, and also making sure there is equity and diversity in our new marketplace. We don't like to see, the Marlboro of cannabis necessarily. We want to see responsible local licensees making up the market if possible, knowing that that's not going to be completely possible, and so that's really why we were engaged in helping draft a lot of the language in the current law and advocate for its passage. I come also personally to this work. I was born and raised here in New Mexico. I went to University of Washington School of Public Health and worked in rural health around New Mexico, but also in state government prior to my work Drug Policy Alliance, so I understand sort of the importance of good governance and regulation and oversight and the roles of this body and the sister agencies. So I now serve as the chair of the Cannabis Regulatory Advisory Board, which is in the Regulation and Licensing Department. So we have spent the last 10 months really helping support the drafting of the rules and regulations, as well as we are tasked with helping come up with procedures to ensure that there is equity and diversity in the market. And I will, after I speak, I'm going to put a couple links in the chat so you can see some of that work. You can see who's on that board. Most recently, we provided a report and recommendations to the Regulation and Licensing Department on who should qualify as an equity applicant. And as many of you know, and very proud that the New Mexico Finance Authority actually was able to create a fund to support licensees who fall into an equity category. So those are potential tribal members, Acequia, Merced. There are other historic communities. Let's see, did I say Acequia communities, land grant communities, and other populations and communities that have been disproportionately impacted by the prohibition of cannabis. And actually medical cannabis patients are also one of the qualifying conditions for equity, are medical patients that have been disproportionately impacted because of their medical status. So I will share a link. It'd be too much to get into today, but happy to come back if you'll have me and I could walk through sort of the equity components of the statute. So we've been working very hard to get to provide feedback on the rules and regulations. And now that April 1st is here, we're suddenly going, what's our role? What do we do now? But clearly, there's going to be a very important role in assessing and evaluating whether those rules are the right rules and whether there need to be tweaks, and what are some of the unintended consequences, what are some of the impacts in the community. So we will continue as an advisory board. But I was talking to Dominic about, how could we be working together, since we are really focused on the regulatory piece of adult use and medical cannabis. We know that those regulations will have impacts on public health. As this program rolls out, looking at youth access is one, or as someone brought up around quality standards, or is there enough access for medical cannabis patients, the right types of products, enough product, quality products, etc. So I would love, if there's an opportunity, we could bring these boards together and learn from each other, so that the regulatory body can really make some important decisions rooted in the public health of our community. And so really, that's all I wanted to sort of share and introduce. We meet quarterly now. Our next meeting is going to be, I believe, May 7th, but I will, it's not finalized. I will share that information with Dominic, and it could be, we'd love your participation. They are open meetings just like yours. And so, yeah, that's our introduction. I will flag, and I was happy to see, Libby, your presentation around some of the education, because we have, as a board, have been getting a lot of questions about community-based education. And I see that not necessarily as our role as a regulatory oversight advisory board, but that might be, obviously fits more squarely in the role of this group, but how can we help push out that education material that's being developed to the constituencies and the communities that we represent in that on that board. So with that said, I'd love, if folks have questions about how it's going, or data we're collecting, or equity, I'm happy to help try to answer those questions or get that information to you from the Regulation and Licensing Department.
Thank you, Emily. Does anybody have any questions? I will say I would love to know more about your meetings. I think that would be great if Dominic, if you and the team could send those out to us, because that is something that's going to help at least me learn a little bit more about what else is going on. So I think that's a great idea, Emily. And of course, you're always welcome at our meetings. But I think that would be very helpful to sit in and kind of learn a little bit about what you guys have been doing and figure out how that can be together.
Great. I'd be more than happy to do that. And I also wanted to just flag, and maybe this, there are folks in Colorado. We actually, the language around this Public Health Advisory Board was very much modeled off of a Colorado board. And I'm happy to provide, if there are contacts or lessons learned from that group, I'm more than happy to connect you all with that. But I thought their model was really great, and they focused on, one of the big issues was pregnancy and cannabis use. And obviously that's of utmost interest and concern here. So again, if there are any ways I can make connections to other folks in the field around the country, I'm happy to do that.
That's great.
Emily, if you don't mind sending me the information for the next meeting, I have been checking on the Cannabis Control website, and it still has the March meeting. So if you can send that, that would be great. And then I'll forward it to all the committee members here as well.
Wonderful. Thank you.
That'd be great. Thank you. I know I've brought up in the past about being concerned about, I know when Colorado put out their public health, like here's their report that places have been cherry picking out information. And, one of my concerns is that we don't allow individuals to cherry pick and report information that's not taken out, out of context, improperly out of context. So thank you very much. Any last questions? Thank you very much, Emily.
Thanks, everyone. And I'll put a link to the equity plan in the chat.
Great. And then I think we're ready for our next presentation for the public health surveillance. Is that where we're going next?
That is correct, Ryan.
Okay, great.
Great. Let me share my screen so you all can see my PowerPoint here. Are you all seeing these slides? Okay, great. Sorry, it always rearranges where everything is on the screen, doesn't it? Okay, so I'm Haley Peterson. I'm part of the substance use epidemiology section here at Department of Health. And I'm just going to give an overview of public health surveillance of adult use cannabis. So we'll, summarize current surveillance activities in New Mexico, and we'll also discuss other data systems that we can explore and ways to expand our surveillance capacity here in the state. So this slide, you probably are all familiar with the reporting requirements of this committee and of DOH. But beginning in December of 2024, this committee and Department of Health will be expected to start publishing an annual report on the health effects of legalizing cannabis products and elements related to all those things listed here, things like child access, road safety, consumer and product safety, poison control center calls, etc. And then I share this map on current state policies on adult use because I think it's important to point out that we're not the first state to legalize for adult use. So we do have lessons learned from other states. Colorado and Washington were the first states to legalize. As of February 2022, there are 18 states that have legalized for adult use. And we put an asterisk on South Dakota there because even though they were part of a group of states that voted to legalize in 2020, they've had significant legal challenges to their law. So at this point, I wouldn't consider them a legal adult use state. But New Mexico joined the legal adult use group in April of 2021. But I will point out, of course, as you all are aware, that we've had medical cannabis program for many years, and then we actually did decriminalize cannabis use in our state in 2019. So just to give an overview of the surveillance systems that we'll want to focus on for monitoring public health impacts in this topic. We have several population-based surveys in our state that have cannabis-related questions. So we have the Youth Risk and Resiliency Survey. This is a survey among middle school and high school students in New Mexico, sponsored by the CDC. And we have really good quality data from 2001 to present. So it asks things like questions about current use, age at first use, and then in 2019, they did add a question for driving after using cannabis. We also have the Behavioral Risk Factor Surveillance System, another CDC-sponsored survey. This is a telephone survey among adults, and we added cannabis questions there in 2020. We have the Pregnancy Risk Assessment and Monitoring System, another CDC-sponsored survey. This is a survey among new moms. And in 2017, the Council of State and Territorial Epidemiologists, there's a cannabis subcommittee within that group that I'm a part of. They sponsored an extended supplement that asks a bit more detailed questions about cannabis use during pregnancy. But as of right now, they only have 2 questions that relate to cannabis on that survey, and that's about use in the month before pregnancy, and then if they've been asked about their substance use during their prenatal screening, and it lists several substances, cannabis being one of them. Then we have a couple others. We have the New Mexico Community Survey. This is a SAMHSA-based survey that the Behavioral Health Services Division helps run. And they did an extended module on cannabis use beginning in 2020. So they asked things like questions about current use, methods of use. They also asked where people were purchasing their cannabis. So they've got some interesting data points there. The only thing I will point out with that survey is that the counties can opt in or opt out of these optional modules. And so I believe in 2020, they only had maybe 2 or 3 counties that answered the cannabis questions. So it's still an important data point to have, but maybe not quite as representative of the whole state as say the BRFIS is. Then we also have this National Survey on Drug Use and Health. That's been around for many, many years, but the easily accessible data online is available from 2002 to present. So they ask questions about current use, age at first use, and perceptions of risk. And then I'm just going to give a couple snippets of data today. I didn't want to go too in depth, as I know that there's a lot of other stuff to cover today. But if you have any additional questions about any of the data sources I'm going over today, I'm happy to come back and talk more in depth about it in the future. So this is looking at our YRRS data, so the data among high school students in New Mexico. And we can see that the trend line has really been stable for many years here in our state. In 2019, 27.7% of our high school students reported current use of cannabis, and that was the highest rate in the country. And then if we look at our adult use of cannabis, I point out that this is pre-legalization because these questions were asked in 2020. And that's after decriminalization, which happened in 2019. But we had overall 15.3% of New Mexico adults reported current cannabis use in 2020. And then if we look by gender, there were more males than females that reported current use. And if we look by age group, we can see that the younger age groups were more likely to report current cannabis use than the older age groups. And then we have some additional surveillance systems. These are sort of the main ones that most states that are doing this use. And again, I'm part of that Council of State and Territorial Epidemiologists where we're all learning from each other, the EPIs that work on this cannabis topic. And there's been several conferences on cannabis public health surveillance. So these are still sort of the strongest surveillance systems that all the states seem to turn to at this point. So we have the New Mexico Poison Control Center data. They've been a great partner during this time. And the Poison Control Center data is really great because it can help ascertain cases that do not end up in the hospital system. And I think that's especially important when you consider the Poison Control Center number is included on the packaging of cannabis products. So you may have someone that experiences an adverse effect of using a product. They may call the Poison Control Center for advice, but perhaps they decide not to seek medical attention. So you still might get that report, though, of the adverse effect that they experienced in that case. And they've also been helpful for identifying outbreaks and unusual events. So for example, they helped us identify some of the cases of the electronic vaping associated lung injury outbreak that started in 2019. So it's a very useful data source that way, and it's a rapid, recent data source too. So we're not having an extreme lag in the data that we're getting from them. We have the hospital inpatient discharge data. This would come from our Department of Health Systems Epidemiology Program. This is an annual data file that can be used to determine the number of hospitalizations related to cannabis. And typically that's ascertained by looking at the ICD codes related to cannabis use associated with hospitalization visits. However, this is an annual data file, so that means there is significant lag in the data. So typically, once the year closes out, it still takes several months after the year closes out to receive that data file. So this has significant lag to it. We also have the emergency department syndromic surveillance that's accessed through the Essence platform. However, the health systems EPI program is again sort of our resident experts here at Department of Health on the Essence platform. So they will assist us with accessing that. But syndromic surveillance is great because it can provide near real-time data on emergency department visits. So in this case, even though there's data that can be in the system even 24 to 48 hours after a visit occurs, I really would recommend we wait at least a month before looking back at the data. Just the data becomes more and more complete over time. And so I would still recommend we at least give it a month lag to let that data become more complete over time. Some caveats with both the hospital data and the emergency department data, though, is currently these do not include federal facilities. So it won't include IHS facilities or veteran hospitals. So that's just an important thing to note when we're looking at those data systems. And then the syndromic surveillance, we would typically say that that should really be used to monitor trends and not to necessarily consider it an exact count. And there are several reasons for that, but particularly with cannabis, it's still being explored, sort of the predictive value of some of those ICD codes being associated with an emergency department visit that's directly related to cannabis use. So, for example, there are ICD codes for abuse and dependence of cannabis. Sometimes if you look at those visits, perhaps that ICD code was assigned because the person happened to mention that they used cannabis, but not necessarily because that visit was directly related to their cannabis use. So it's just something to keep in mind that the trends will be important to keep track of, but not necessarily the exact count of visits. And then we have a couple other surveillance systems to talk about. So there's traffic safety data. Of course, that's going to be of a lot of interest. I think I, at this point, have not worked with this group myself, but the alcohol epidemiologist in New Mexico is part of the same team that I work on, and I know that she gets her DWI data from the UNM Traffic Research Unit. I was looking at some of their current reports that are available online, and right now they do not have a cannabis specific category. That might be something that we want to ask them, you know, where they see that data going in the future, but that I imagine will be the group we'll work with for that data. And then sales data is another one that has been important for some states. I would assume that if we have that publicly available, that'll come from the Taxation and Revenue Department. But I've seen like Oregon has a really great data dashboard where they show their sales by product type. And so they've been able to track that in the last couple of years, concentrated THC products are becoming an increasing share of their sales in the state, and concentrated products can come with their own public health issues. And so I think it's really great that they have sales data that's by product type in their state. So that might be something we'd want for our state as well. And then just another little snippet of data. This comes from the New Mexico Poison Control Center. Again, they've been great partners. This graph here shows the annual number of calls to the Poison Control Center here in New Mexico related to cannabis. And one interesting thing I'll point out here is that 2014 is actually when Colorado had their retail market open. And you can kind of see a clear increasing trend here in New Mexico after Colorado had their markets opened. And then we also have established weekly reporting between the Poison Control Center and our group as of the beginning of this month. So we set that up just knowing that there may be an increase in the number of calls after markets opened here in our state. So for all of March 2022, there were 18 cannabis-related cases reported to the Poison Control Center. And then Department of Health, we actually, medical cannabis program spearheaded it. We worked on it together, a health alert for the health network. Maybe you all are familiar with that, but essentially it's a health alert that goes out to a group of medical that are signed up for that. We did release a health alert the day before our retail opened here, just giving sort of a heads up to providers that, especially with edible products, there could be pediatric exposures of kids getting into those edible products. And we did ask that those cases be reported to New Mexico Poison Control Center. However, reporting is voluntary. So we may have seen an increase as it was brought to the forefront of providers' minds to report those cases, but it is voluntary. So whether or not we received all case reports, I'm not sure. But for the first week from April 1st to April 7th, there were 21 cannabis-related cases reported to the Poison Control Center here. That count did include that classroom exposure that you all may have seen in the news, where 14 elementary school-age children got into essentially some gummy candies. And then we see sort of a drop off in the next couple of weeks. So from April 8th to April 14th, there were 8 cases. And then for the last week ending on the 21st, there were 5 cases reported. So whether or not that drop off is because now it's not necessarily at the forefront of everyone's mind, or if perhaps people are now safely storing their cannabis, we can't be too sure at this point. But what's really great about the Poison Control data is that we've got really good data on what the product is that was involved in the incident. So at a minimum, we have the type of product, whether it was a vape or an edible product, but they're also trying to collect product names from folks when they get these cases reported. So that could be useful if, say, in the future, we start to see one particular product name popping up consistently. We would want to maybe investigate what's going on with this product in particular that's causing so many adverse events. But it's a really great data source, just because with our emergency department data and our hospital data, you'd probably, if you were going to find the product type, it would probably be in maybe the chief complaint or like a triage note, because there's not necessarily a specific field in those databases for the product type, because not every visit is a cannabis visit. So it's a lot harder to ascertain which product was specifically involved in those visits, whereas with the Poison Control Center data, they're collecting that every time they're getting these case reports. So it's really great for that. But we can see here that 69% of these calls that happened in this sort of month and 3 weeks, you could say, of data, 69% were related to an edible product, and then 62% of the calls were for pediatric cases aged 10 years and under. All right, and then just to wrap up, so that I don't go over too much, hopefully for my time slot, but these are looking at ways to expand our cannabis public health surveillance capacity in New Mexico. So number one, I think it would be really useful to employ epidemiologists that are specifically focused on cannabis. This is a topic I've worked on for a few years, but technically it's a side topic for my job. So it'd be a really good idea. I think there's tons of data to explore. This is an ever-changing, ever-evolving field at this point. So having epidemiologists that are specifically focused on the topic would be really valuable, especially when we start looking at working with this committee on publishing that annual report that's going to be required. And then we can expand the capacity of our current population-based surveys here. So for the BRFIS, that's that survey among adults, we could increase the sample size so that we make sure we have a strong sample each year for these questions. And then we do need to make sure we're covering the cannabis module costs. So if we want those questions to continue on the survey, we do need to make sure that gets covered every year. And then for the New Mexico PRAMs, that's that survey among new moms, we could expand the types of questions that are included on the survey. So like I said before, right now they're asking about use in the month before pregnancy, and if they're being asked about it at their prenatal screening, but we could add back in those questions about use during pregnancy, and also maybe even ask their reason for using during pregnancy. Perhaps, they're using it for nausea. It might help us sort of tailor our public health messaging there. And then other states have also done cannabis user surveys. So if we felt there was a need to sort of explore in more detail about cannabis users and sort of how they use their cannabis, or maybe some of their health behaviors with using cannabis, we could do a callback survey. So for example, on the Burfess, you could take the set of people that answered that they do currently use cannabis, and then you could call them back at a later date with a more detailed survey about their cannabis use. Or some states have employed web-based surveys where either they might have it advertised through different online platforms to sort of reach the general population, or they might set up tablets at different dispensaries in town or at festivals that are related to cannabis so that they can get more at sort of the cannabis using population to ask them specific questions. It would just depend on what we're interested in ascertaining there. Another useful tool that I think we could explore is creating a poison control center data dashboard. So that would sort of help automate this data update from the poison control center. It could be a publicly facing dashboard, so it would be publicly available to look at the number of cases that are related by product type, by age group. That could be a good avenue to explore. And then this last point here that I bring up, the International Cannabis Policy Study, that's something I bring up because the Council of State and Territorial Epidemiologists, I know that there are several legal states that are working more closely with this group now. It's actually a team that's from Canada, but they have been tasked with researching policy and doing sort of this very in-depth cannabis survey, both in Canada and in the US. So they ask questions in both legal and not legal states in the US. But I know that some of the legal states are working more closely with them now so that they can get better state-specific estimates from the survey for their state. So that's just another idea I bring up just because it's something I've heard about frequently. All right, and if there's any questions, I'm happy to take them now or bring back more stuff later on. Thank you.
Any questions? Thank you very much.
So I have just 4 quick ones, if that's all right.
Yeah.
The first is, are there data on the validity of the questions asked on the surveys? We know from in the past there's underreporting, and just wondering what they've been doing to try and do that. Let me just ask all 4 and you can answer all 4 quickly. The second is, will we start using a denominator at some point? I don't know what that should be, number of units, grams sold, number of, some number that would make sense cumulatively and individually so that month by month we can understand what the risk is on the denominator side versus what the actual problems are. And then I'm wondering if the sales data can be used to also look somehow at underreporting if there's a huge sales and we're not seeing much increase in survey users, if there's some way to adjust in that regard.
Yeah, so with the survey questions, particularly for the YRS, the PRAMs, and the Burfess, I know that those questions have been cognitively tested, which is typically what you want to do with any new survey questions. So those have been cognitively tested, though there has been some concern. Right now, I know with the Burfess, we specifically tell them to not answer about CBD use. But there has been some concern if people may confuse sort of their CBD use with their THC use in some of those other surveys. So that's been something that's been discussed over time. With some of the extended modules that have happened on other surveys, maybe some of those additional questions haven't been cognitive tested at this point, but hopefully with the way they're worded, we're getting good data. And hopefully over time, with some of those extended modules, if they just started in 2020, hopefully we'll see how that data changes over time to see if we can maybe identify any issues with the questions that way.
So sorry, when you say cognitive, you mean validity, or you mean validity and reliability?
Right. Yeah. So cognitive testing is typically what those questions will go through. So for example, like the CDC has had cognitive testing where essentially they're taking those questions, having people take the survey and then sort of doing a focus group with the people that take the survey to ask them, well, how did you interpret this question?
How do
Like,
you
what were
understand it? Yeah, so that's the
Yeah.
validity side, and I'm wondering about the reliability side in that case.
Yeah, at this point, those questions seem to be pretty reliable. They're asked in a pretty standard way. So for like the current use question, it's asking about use within the past 30 days, and that's pretty standard. That's the same way that the tobacco use questions are asked, alcohol use. So those are considered pretty strongly reliable and valid at this point with the way that those questions are worded.
So there's no concern that they're being underreported in that respect. Because a reliability would also ask, you know, how do you test against some other objective measure that you can test against the responses in some form?
Right, yeah. And so that's another thing where having these different surveys can also help us sort of see how they all line up. So for example, with the Burfus and the New Mexico Community Survey, they are kind of different samples since the community survey is just sort of in certain counties. And then the Burfus is a telephone-based survey that's statewide, but it does help us see, you know, are the trends matching up over time? The National Survey on Drug Use and Health, that's another one that, you know, is long-standing. I tend to think that our state is underrepresented in that survey, so I tend to think that there is an underestimate in some of the data that they have there. But another, again, like if the trends are matching up, I would say that those are pretty reliable at that point.
This could be an interesting topic for a future one. I don't want to spend much more time on it, but to understand how, you know, how valid are the data, not necessarily the surveys, but the data themselves, to understand if we're actually capturing what's a good picture of what's happening in the population.
Mm-hmm. Yeah.
And Haley, Haley and Haley, I would say this is definitely a topic that we can bring up in either the next meeting or the meeting after that. But we do have one more presenter, and we may end up going a few minutes over if that's okay with folks. But I think if we can, we could reserve some of these questions for the future, because this will not be the last time Haley Peterson will actually be joining us, as she is one of our key epidemiologists and one of the folks that we'll be inviting on a regular basis.
Good, that'll be great. Thank you.
Yeah.
Thank you all for your time today.
Thank you. I think it'd be great if we could see if maybe we might have time to schedule that during the next meeting, Dominic. I don't know, but I know I've got a list of questions I've been writing down. So I think this is very exciting because I've been worried about, you know, where are we going to get this data, you know, and, you know, and that URBS, it used to be URBS, I'm going to show my age, that YRS study, you know, is asking things like seat belts and do you wear your bike when you're on a helmet? So I think a lot of kids, you know, it's a lot of questions where hopefully they're not like, oh, I can't be truthful on this question because they're asked so many questions. But this is super exciting. But yeah, I think it'd be great if we could steal you again for another meeting so we can have people answer questions or ask their questions. I'm sure they have.
Yeah, and Ryan, just to let you know, we've already been talking about that as how we move forward with it. And I think part of the reason we have so many presentations today is actually because the data that's available and starting to become available is a lot more readily available. And we have a lot of very exciting things coming up in the future. And
Awesome.
So we wanted to give you more of from the committee standpoint, a taste of some of the things that are available so that you can see how much is really there. And there's yet more, because UNM, for example, and I'm sure Katie or Mateo could jump in on this, but has quite a bit of data that they've been gathering through various research and studies, and we haven't even really started talking about that yet. So,
great.
Yeah.
Thank you, Dominic. Okay, moving on to our last presentation, Michael. We have a research project presentation. Do you want to go ahead and start?
Can you guys hear me all right?
Yes.
Yep. All right. So let me share my screen. So this is actually really more of a It's a national survey we've been doing. When I get started, because we're a little behind on time, quickly here. So essentially, some of the limitations of existing logical data that I think we just brought up, the big ones are just usually a pretty long lag, oftentimes to anywhere 40 years. They're also usually annual, so if there's any changes within the year, you can't really understand, like kind of pre-post, or there's no real ability to understand causally what's going on, because of that temporal, that time-based resolution is kind of low, if you will. Sometimes states don't participate in all of these data, and so it's inconsistent. There is some evidence that studies like NESDA can pretty dramatically underestimate cannabis use, to the point where most state reports on like cannabis demand pre-weight like National Survey on Drug Use data, to assume that a greater proportion of cannabis is actually being purchased and consumed. And oftentimes, I think Haley mentioned this pretty well, there's very few cannabis related outcomes. It's, you only get maybe cannabis use, or if it's prams, you might have something more focused on pregnancy related outcomes, but it really leaves a little bit of something to be desired, right, in terms of the breadth of outcomes. So I'm just going to really quickly, I'm going to go over sort of the methods we use, and then I'm going to present some of the initial findings. I just got this data, like literally I stopped data collection yesterday. And so it's a little bit raw, so apologies, not as so in our survey, what we've done is we've recruited from essentially community research panels that where participants have no idea what surveys are about, and they pre-select things. So in terms of their like demographic characteristics, say, oh, I engage in cannabis, or I do this to get into a survey. So some of the potential biases we got. Everyone is 16, ages 16 and older. 20 states, with New Mexico being one of them. And it was recruited essentially last week, and so we can recruit. We got about a general population, data that has like essentially whether they use cannabis daily, in the past week, in the past month, past year, past 2 years, and I think never are the categories we get, and we get that for about 13,000 people in the United States, with New Mexico again being one of them, and then we have about 230 other cannabis-related outcomes, specifically for about 6,000 people, about 150 of whom this past time we recruited from New Mexico. Again, trying to get that much more breadth and kind of in-depth data on what's going on with these individuals. And that's across public health outcomes, market outcomes, medical cannabis specific outcomes. We have data on a lot of other topics related to, we have an entire opioid sub sort of, basically participants who say that they've used opioids illicitly on any level recently, or prescription medications that in a way that wasn't intended. They get sort of triaged to a different set of questions regarding their medication assisted treatment use, and a bunch of other things specific to opioid use disorder and potential recovery related aspects. But I won't go into that too much. These are the other states that we're assessing. So often adult use states, but also medical. It's about a 50-50 split. We like to get sort of regional so we can understand sort of what's going on to other states, and with potential diversion issues. And so these are the main states. These states together with the US population represents about 2/3 of the US population. So they were picked in part for that. New Mexico was picked in part because we've worked with New Mexico in the past, and we find them to be really good stewards of public health and safety. And so we're providing that data to them for free. Or as we work with other states as well and other organizations. This is a quarterly survey, I think. So I think Haley also brought up the International Cannabis Policy Team. We do a similar thing, except we're doing it quarterly at least, if not where we hope to little bit more frequently. And the idea again here is it's not just that it's up to date, add it about a week and turn it around, but that it's also that we can sort of separate things. In other words, we have data where in New Jersey, we collected data all the way up until the day before they implemented their adult use, the first adult use open, which was April 21st. And so we have, that allows us to make really careful pre-post comparisons. A lot of the questions we asked are fairly standard. We do take a lot of questions from surveys like the National Survey on Drug Use and Health. What Haley talked about with they are. However, we have cannabis use patterns, the methods they use, the frequency, amount, and we also separate where they're getting cannabis from. And so, for example, we know based on our initial look at the data that a lot of cannabis was purchased, and maybe more so the first since adult use has been implemented relative to medical in the state of New Mexico since the start of April. So kind of interesting stuff there. Other drug use as well, or substance use as well is presented. I'm not going to mention these all, but there's many, I think, relevant public health and safety outcomes. It's not just things like problematic use or cannabis use disorder, but there's a real prevalence of Delta 8 use in New Mexico and well, counterfeits more like, you know, people putting edible products or like sort of infused products and like looking more common than you might think. We have pretty detailed data on the prevalence and number of days people drive under the influence. So when individuals say I've driven under the influence in the past month, usually they're using, like our average is about 6 to 10 days a month. So it's not just that they're using one or driving once under the influence, they're driving frequently under the influence. Hospitalizations, related cannabis and in general, occupational related, you know, like workplace impairment, use during pregnancy, co-occurring mental health issues, and physical. Also relevant variables too, we have other variables that we think could be helpful in terms of understanding, sort of helping you all focus on, okay, well, what might be going on here? You know, think whether it's medical patient status, or how long, exposure to advertisements, you know, prevalence on how often people are going to dispensaries, different conditions, people have, you know, certain people at greater risk based on their pre-existing medical conditions and actually what they get their cannabis recommended for. And we do have an entire subset of questions. We have hundreds of people that we have data on this overall, at least in the US, in terms of what are medical recommenders actually, you know, who are they, what are they doing, what are their tendencies, what are their preferences, what do they think works well, how do they go about deciding what and when to recommend cannabis to individuals. And then obviously, as I mentioned before, we have a co-occurring illicit opioid and cannabis use subsection. So the big picture findings here amongst participants here that said that they had used cannabis in the past year. So that's what I've analyzed so far, just more general pop data. But basically the idea is that it's New Mexico is looking pretty similar to these other legal cannabis states. So remember, these are all legal cannabis states, and basically the prevalence is very high. So almost, this is saying about 46% of people, or sorry, 40% in New Mexico are using, of those who use in the past year, are using almost daily. If you actually look at data from other studies that have come out in recent years, in about 2019, 2020, and you track to now, this is actually a pretty consistent number. It's just that a lot of the other federal surveys don't report these kind of prevalences. But independent researchers and other large scale studies have shown consistent numbers with this. So amongst youth who have used in the past years, it is more common for them to have used in the past month. What's interesting though, and very positive so far, at least like at this point in time, I should say, is for New Mexico relative to these other legal states, we are seeing lower rates for vaping and concentrates, but similar rates for smoking edibles compared to other states. So generally, you would assume that's generally a positive. In terms of cannabis use disorder, we are seeing another positive note here where New Mexico is essentially has a much lower proportion. So of those who have used cannabis in the past year, there's a much lower proportion in New Mexico compared to other states that are legal. Similar pattern with percent hospitalized for cannabis-related issues. Only 1.3% of those who have used cannabis in the past year in New Mexico, but 7.4%. So these are pretty dramatic differences here that are quite significantly different. The only one that I found that was actually, so far at least, I shouldn't say, it's not comprehensive yet, but that there was actually a difference that wasn't in the more desirable direction is that age of first use. So younger individuals are basically, so they start younger. So just like a quick summary of these, New Mexico was a little bit worse than these other states in age of first use, but it wasn't necessarily like a crazy difference. I didn't report drug under the influence yet. I did have that in there. I apologize. I can provide an update afterwards about that. And cannabis use disorder and cannabis-related hospitalizations did show better related outcomes compared to so I just think it's important that we continue to track and monitor these things moving forward, and we're going to be doing that quarterly anyway. We can always add more. We plan to add more anyway, but it's great to have samples to start to get at sub-geographic levels. In other states, we recruited similar sizes to Mexico, about 1,000 people, and then we actually start to really understand some regional differences in the state in terms of where things might be worse or where particular public health related issues are coming from. We also have been incorporating, so at the same data set that we have here, we've incorporated other sort of policy variables, state-specific and state-specific variables and outcomes from other data sources, like places where adult use in medical stores are and things like that, opt-in or opt-out states, certain county or different policies that might vary by county, and then projecting, understanding how those impact current outcomes with cannabis, and then predicting out how that might in the future, certain policy moves might change outcomes related to cannabis. And then some other relevant insights could be using data from, how are medical recommenders providing, they're talking to patients about risk associated with cannabis use disorder. Are they using stigmatizing language that might reduce the likelihood they come back, which is really what we want them to be engaged. Things like that, I think could be really helpful. That is it for today.
Great, thank you very much, Michael. Does anybody have any quick questions? I know we're kind of over time already. See if anybody had any quick questions. Michael, we might think of questions afterwards and then beg you to come back again. So
sounds good. Sounds good.
Yeah, so thank you very much for that presentation. I think that was really, it's exciting to see all these resources that we're able to get. So it's pretty exciting. So thank you very much for your presentation.
No worries.
There's a couple more, moving on, there's two more items, discussion of research and resources and other items for committee members. If it was okay with everybody, since we're running over, maybe we could postpone those or add those to the next agenda meeting. Is everybody agreeable to that? Is there anybody that is not agreeable to that?
I would so move.
Any comments? Okay, we'll go ahead and Dominic, if we could move those two on. The scheduling the next meeting, did we kind of come to a consensus that we were going to keep this on the same schedule to whatever day this is, the Tuesday, the whatever it is, the third or fourth Tuesday? Fourth Tuesday, I can't quite remember how we did that.
So Ryan, it wasn't a specific on moving it to a specific Tuesday or anything, but it seemed like the third or fourth Tuesday every other month has been working for most people. So I would recommend, if that's something you all would like to do, we definitely can do that as part of the scheduling. And I was already going and looking at that, and so we would be looking at June, and the third Tuesday for June is actually the 21st of June. Or if you wanted to go with the fourth Tuesday, it is the 28th.
Do any members have something that they can't move around on the 21st or 28th?
So, and maybe for consistency, I'd suggest the 21st.
For the 21st?
Yeah, that way it would be the third Tuesday of June as well.
Okay, yeah, because today's the fourth Tuesday of April.
Oh, is today the fourth? Oh, you're right, it is. Sorry, I was looking at the wrong month.
Okay.
Yeah, so if that's the case, I would say if you want to go with the fourth Tuesday, then the 28th of June.
Okay, that'd be
the only consideration I would have, and Ryan, I know this would affect you as well as some other people, is that the June 30th is the end of the state fiscal year. It would be okay for us. I know sometimes some of the organizations that have contracts and things like that, that becomes a very busy time. So that might be the one thing you might want to think about on going with the 21st.
For Katie and I, we will be at a conference at the 28th, so the 21st would work better.
Okay.
Sounds like the 21st might, that's the only comment I've heard so far about the 21st, 28th. So 21st, is that okay with members? Does anyone have an issue with the 21st? Seeing thumbs up. Thanks, Alan. Okay. Well, I guess, do we need to do a vote for that? That we'll have the meeting on the 21st? Consensus. Yeah.
Yeah. And we will go ahead and schedule that and get the calendar invite out to everybody.
Great. Okay, and then we'll move those other two items, and then looks like we have that meeting scheduled. Entertain a motion to adjourn the meeting. From anyone? Matthew, I saw you raise your hand.
Make a motion to close.
Awesome.
Adjourn.
And a second?
Second. Sorry, this mute button is tricky.
It's okay. It's okay. Thank you very much, Mateo. So the meeting is adjourned. Thank you, everyone.
Thank you, everybody. And
thank you all. Have a good day.
Ryan, thank you so much for stepping in.
You're very welcome. Yep, no problem. Thank you.
You have a good voice to chair.